Welcome back, everyone. Today we'll be talking about skin and soft tissue infections. When approaching skin and soft tissue infections, it is important to keep your differential broad. For example, is this cellulitis, stasis dermatitis, or a DVT? Once you've made the diagnosis of cellulitis, you should have the familiarity with the most common bugs and risk factors in order to tailor your antibiotic selection accordingly to your patient. The learning objectives for this talk are to be able to identify cellulitis and to be able to discuss different treatment options. Things to consider when dealing with a possible skin or soft tissue infection include the following. You should be thinking about the patient's presentation, the rapidity or chronicity of the lesion at hand. Is the patient having any systemic symptoms such as a fever, chills, or drainage from the area? Was there any penetrating trauma to the area? And then what tests should you order? Like a CBC to look for a leukocytosis, or inflammatory markers to look for an elevated CRP. And if you're not sure exactly on the diagnosis, what additional tests can you order to help guide your decision, like a Doppler ultrasound to look for a blood clot or a superficial ultrasound to look for an abscess. When choosing antibiotics, it's important to determine which one are you going to give this patient, IV or PO, and when should you broaden the coverage to include additional bugs because your patient actually has risk factors. And lastly, how can I ensure that this patient has the best chance of healing besides just providing antibiotics? Case 1. A 68-year-old male with congestive heart failure, chronic lower extremity edema, diabetes mellitus, and end-stage renal disease treated with intermittent hemodialysis through a tunneled right internal jugular venous catheter presents to the emergency room with abrupt onset of right lower extremity pain associated with redness and swelling that evolved over a period of several hours. So here are the images for our case above. And when performing a skin exam, be sure to pay close attention to the borders of the redness, looking for irregular borders versus clearly demarcated. Look for open skin lesions, and always perform a foot exam, as poor foot hygiene can be a gateway for pathogen entry. Always compare the extremities at hand and look for asymmetry and swelling. And lastly, feel both areas and assess any warmth. And then a good habit to get into is on the initial presentation, outline the erythematous border with a dark marker, as it can aid if your interventions are improving the clinical course of the patient or not. So given the above case, what is the most likely diagnosis? Here we have a case of non-purulent cellulitis, and if you were thinking erysipelas, that's reasonable, and we will discuss the differences. Both are painful bacterial infections of the skin. However, cellulitis involves the superficial dermis, has irregular borders, and a slow progression, as opposed to erysipelas, which likes to get into the deeper dermis, into the subcutaneous lymphatics and blood supplies, which makes sense given it has direct access to the lymphatic and blood vessels. It usually spreads much more quickly, and it has more distinct borders as opposed to cellulitis. The redness kind of stops abruptly, as opposed to cellulitis, which just kind of fades away. Both will entail swelling from the local release of cytokines. And given this may seem straightforward, you will need to still consider the possibility of a DVT or stasis dermatitis. And if you look at this picture here on the slide, you can see how similar all three of those presentations can look. And lastly, something you cannot miss is necrotizing fasciitis, which we'll talk about on the next slide. Necrotizing fasciitis is an infection you do not want to miss. Here the organism penetrates down into the deep fascial layer, ripping through the vascular and neural supplies, The destruction of the vascular supplies presents as an ecchymosis, and when the skin dies, it necroses and liquefies, turning into bulla and skin blebs. The neurons become inflamed, which is extremely painful. However, you can get a paradoxical paresthesia, which results in numbness, meaning that the nerves are now dead. This is actually a bad sign, and the patient may actually think they're getting better. You may also be able to palpate some crepitus on exam, or get some imaging and see some gas on x-ray. However, this is a surgical emergency, and our surgical colleagues must be contacted ASAP. No amount of antibiotics we give this patient will help because the blood supply is destroyed and we cannot obtain source control. If you are unsure of the diagnosis, you can use a scoring tool known as the Lernick, which is the laboratory risk indicator for necrotizing fasciitis, which helps guide our decision making. But remember, if you have a pre-test probability that is very high, do not wait on some of the labs to return to calculate the score. Contact our surgery colleagues immediately. I've provided some literature on the Lernick score here at the bottom of the slide. Most common pathogens for skin and soft tissue infections include your Staphylococcus aureus and your Streptococcus pyogenes species. It's hard to differentiate between the two, but signs to look for include pus or purulence or fluctuation with palpation, which are seen in your Staphylococcus species, as opposed to the strep infections. You don't have these findings, and they're more consistent with an erysipelas picture. You do need to be worried about gram-negative bugs. They can cause cellulitis. It is more rare, but it's more common in your patients with poorly diabetic foot wounds, homelessness, IV drug users who actually lick their needles prior to injection. Then when determining disposition, things to consider: is this patient having systemic symptoms, fever, leukocytosis, they're having chills, their blood pressure fluctuating, are you worried about poor compliance, and what are their comorbidities? These are factors to take into place if you think this patient should warrant IV antibiotics in admission as opposed to PO antibiotics in discharge. If the patient has systemic signs of infection, so they're meeting sepsis criteria, and you think it's all from the cellulitic process, then yeah, I think it's fair to try with some IV antibiotics. And what is going to be your IV antibiotic that covers strep, staph, and MRSA? You'll typically see IV vancomycin be used. One step further with the treatment, and that is your antibiotic selection and duration. Now that we know the most common pathogens causing cellulitis, we can choose our antibiotics appropriately. So all penicillins and cephalosporins do cover your staph and strep species unless it's MRSA. And your MRSA coverage is going to be with your doxycycline or your trimethoprim sulfamethoxazole. And then also your clindamycin. And remember, you also get anaerobic coverage with your clindamycin. As far as your IV regimens here on the right, again, your penicillins and your cephalosporins. And then the one that most commonly used is the vancomycin, and that's just because you're getting that added MRSA coverage. Typical duration of treatment for cellulitis infection is anywhere between 5 to 10 days, depending on which source you look at. However, no, there was only one trial that actually looked at duration of antibiotics, and I've cited that here at the bottom of the slide in case you want to read it. And the outcome was that 5 days of antibiotics was non-inferior to 10 days. So I encourage you all to be a good antibiotic steward. Once the completion of the antibiotics have finished, it's important to educate your patient that the affected skin is not going to completely resolve. It will take weeks for that tissue to return to normal and the area to heal. Some signs to look for clinical improvement include, the receding erythema of the area, improvement in pain, and the patient's no longer having any systemic signs of infection, like their leukocytosis is resolved, no longer having fever, the swelling has decreased as well. Once a treatment plan has been established, there are things we can do to optimize the healing process, which I feel are typically forgotten. You want to minimize edema
around the affected tissue to aid with the antibiotic delivery and healing process. You can encourage your patients to keep their legs elevated, avoid standing for long periods of time, consider compression stockings, or even an ACE bandage to the area involved to help minimize the edema. And a fun fact I found was the most common cause of treatment failure is actually failure of the patients to keep the affected limb elevated, which gives this illusion that the tissue is not healing and the patient thinks that the antibiotics aren't working or we're targeting the wrong bug, when really it's just we're not optimizing the healing process. Say we've optimized the treatment and given the antibiotic and things still aren't improving, you should ask yourself, should I expand the coverage? Well, remember the line of demarcation that I recommended everyone draw at the initial presentation? Well, has the redness receded from that line or is it expanding? Has the systemic signs or symptoms progressed? Are they getting worse or are they resolving? And does the area inflammation receding after 72 hours of antibiotic therapy? And if they meet this, then it's something to consider to expand the coverage, but also remember, could there be an alternative diagnosis? Are you missing something? Should you throw an ultrasound on there and look for some underlying abscess, or should you cover for MRSA if you haven't been covering for MRSA? These are things to consider when you're thinking about expanding coverage.
The take-home points for this lecture are the following. Be able to diagnose an underlying skin and soft tissue infection. Know the difference between cellulitis and erysipelas. Be able to identify necrotizing fasciitis. Know the most common pathogens. Be able to determine different treatment options and the duration of therapy. And know how to optimize the healing process and when it's appropriate to expand your coverage. As always, I encourage you to dive deeper into these topics by using the IDSA guidelines for skin and soft tissue infections. I've provided the link below. Thank you.